Hello everyone, my name is Carlos Fambuena and today I'm going to talk a little bit about an interesting study I performed as one of the ESRs involved in the PersonalizeAF consortium. But first, let's do some recap. In the last video, I talked a little bit about my project, what was the main research line and why it was important to do research on atrial fibrillation. As a quick reminder, I will say that atrial fibrillation is a disease in which the electrical activity of the patient becomes chaotic and very disorganized, affecting in this way also the effective contraction of the atria. This disease is very prevalent in the world and mostly in the Occidental countries like European Union or the United States. There are many different possible mechanisms that may originate atrial fibrillation and little consensus on which one is the most important or the one to be tackled. So far in my project, I have focused on one specific mechanism, the rotors. This is just simulated data, but in this slide where I try to illustrate is what a rotor is. What we can see in this animation is that the electrical activity is spinning around just a few points or 1 point at some point of the simulation. And this phenomenon is propagating and maintaining an erratic electrical propagation through an erratic circuit that is non-physiological. This erratic electrical propagation at the end has also an effect on the contraction of the atria. And this is why we care a lot about these kind of mechanisms. As mentioned in the previous video, my project is about driver identification in atrial fibrillation using a specific technology, electrocardiographic imaging. This technology allows us to reconstruct the electrical activity right on the epicardium or the atrial surface from the electrical activity measured on the torso. For that, what we do is to homogeneously place a set of electrodes around the torso and also use medical imaging in order to reconstruct both the geometry of the torso but also the geometry of the atria. This is therefore a non-invasive technology which may have tons of applications for both the diagnosis and the treatment of atrial fibrillation. In the study I want to present today, with name Atrial Fibrillation Driver Detection in the Pulmonary Vein Area by Electrocardiographic Imaging, relation with a favorable outcome of pulmonary vein isolation, we evaluated the potential use of ECGI for patient stratification right before pulmonary vein isolation. Specifically, we studied differences in the spatial distribution of rotors in patients that fully recovered from pulmonary vein isolation, or PVI, from those who returned to arrhythmia 6 months after the intervention. For those who are not familiarized with this procedure, pulmonary vein isolation is a surgical intervention in which the electrophysiologist, by means of a steerable catheter, is able to reach the atria of the patient and isolate electrically the pulmonary veins, as presented in this figure here. With this technology, we were able to reconstruct three-dimensional maps of the atria, as presented in this animation. In the figure, what we can see is that regions colored in red represent areas with a high prevalence of rotations, while blue areas represent very little prevalence. In this way, we were able to identify the main rotational areas as well as quantify the rotational activity in the atria. In summary, the main workflow of the study is presented in this slide. So as mentioned, this was a retrospective study in which patients that with atrial fibrillation that went through pulmonary vein isolation had an ECGI reconstruction in order to obtain the electrical activity of their atrias. This was performed right before the intervention, that is right before the pulmonary vein isolation. 6 months after the intervention, we divided these patients in two different groups, non-recurrence group and recurrence group. In the first group, we had all the patients that remained in sinus rhythm after the intervention, and in the recurrence group, we had all the patients that returned to any kind of arrhythmia after the pulmonary vein isolation. We then analyzed retrospectively the ECGI reconstruction of the electrical activity performed in the day of the intervention, and we ran our rotor detection algorithm on this data in order to identify the main re-entry areas. We then compared different electrophysiological parameters we were able to obtain in the two different groups I explained. Regarding the main results and findings of the study, We could see that the ECGI was able to see a higher prevalence of reentries in the pulmonary veins in those patients that remain in sinus rhythm. That is the normal atrial rhythm 6 months after the electrical isolation. This explains in this way why the intervention actually worked in this group of patients. Complementary to these results, we also saw that patients that returned to arrhythmia presented these reentries more spread in other atrial regions. Finally, I would like to say that I had the chance to present the results of this work at Computing in Cardiology 2021, where I had also the honor of being one of the Rosanna Degani Young Investigator finalists. I also presented some extended results of this work in the Atrial Signal Congress organized by KITE people in October 2021. Thank you very much for your attention, and here I leave all my social media from the consortium in case you want to keep yourself posted. See you soon.